indications, and also they do not mention the made it one and must indication. So the European guidelines are moving towards some restriction of the use of ICD. I just mentioned to you the issue of using multifactorial scores. This is an example of one that was created by Rodenberg. Rodenberg worked with us for quite a few years, and this is out of his work with the made it group. He defined, first of all, he defined a very high risk group. These are patients with creatinine more than 2.5. All of them were very high risk. I'm going to show it to you in a minute. And they were excluded because they did not show any benefit from the ICD. Then he defined 5 parameters, including functional class above 2, atrial fibrillation, wide QRS, age, and mild to moderate renal dysfunction. Each one of them predicted the risk, or in other ways, predicted the benefit from ICD. If you look at this, these are the survival curves. In patients with very high risk, who are the patients with high creatinine, there was no advantage to the use of ICD over conventional treatment. If you look at patients who had none of the risk factors, I mentioned, I'll just show them again. These are the 5 risk factors. Patients who did not have any of these factors, included in the MADE-2 trial, had no advantage for the use of ICD, whereas those who had one or more of the risk factors did benefit from ICD implantation. Delay between the diagnosis, whether it's ischemic or non-ischemic, and the implantation. We know that sudden death is prevalent in patients with recent MI, but we know the paradox that they do not benefit from implantable ICD. So this raises the issue of the use of wearable cardioverter defibrillator for the meantime until the final decision is made. Both the European and the American guidelines recommend a wearable cardioverter defibrillator in the meantime in a 2B indication for patients who had extensive myocardial infarction while waiting for the 6 weeks or 90 days following revascularizations, or patients who were recently diagnosed as non-ischemic cardiomyopathy and have to wait about 3 months of guideline-based therapy. In both these groups, the recommendation is not very strong. Both stick to a 2B indication. I looked at the reimbursement policy in different countries regarding the wearable cardioverter defibrillator because this is an issue that we face very, very often. Prophylactic post-MI use, I know that it's approved here in the United States. You probably use it a lot. And the same applies in some of the European countries, but not in all of them. Regarding the non-ischemic cardiomyopathy, again, it's approved here in the United States, only for transplant candidates in France and other countries, and some countries do not approve it altogether. There was this recent publication not a few weeks ago, I believe, that of the VEST trial that looked at 2,300 patients with acute MI and low ejection fraction who were randomized in a 2-to-1 fashion to wearable cardioverter defibrillator versus no wearable for 90 days. There was an insignificant reduction of arrhythmic death and in death of any cause in the wearable cardioverter defibrillator. So it failed to show any advantage. Only 1.3% of the wearable defibrillator group received an appropriate shock. However, it is strange that only a minority of death cases occurred with the wearable defibrillator on. So there must have been some kind of a compliance issue in this group. And only 9 of the arrhythmic deaths had actually a ventricular arrhythmia. So this study actually failed to show any advantage for the use of wearable defibrillator in the meantime between the diagnosis and the 6 weeks to 3 months after acute MI until a decision is made to implant an ICD. I'll go over some observations that we had using the Israeli ICD registries and compare them to the NCDR and significance regarding guidelines. This study looked at these studies looked at the issue of sex difference or gender difference has been shown in several previous studies as well as in meta-analysis that ICD benefit is lower in women because women probably are less likely to die suddenly or have sudden arrhythmic deaths or device-treatable conditions. And the complication rate tends to be higher in women. We looked at it in our population. I'm not going to go through all this huge table. We compared we gathered the results of 3,500 patients, 600 of them were women. Baseline data were a little different because the women had more dilated cardiomyopathy, but we took all comers and analyzed their results. At least in our group of our registry, there was no difference whatsoever between men and women over time. So the results were exactly the same. This comes from the US NCDR, which came up with a somewhat different result. They looked at almost 40,000 cases of implantation for primary prevention. 1/4 of them were women. And as you can see, the rate of heart failure hospitalization was somewhat higher in women. This is freedom from heart failure hospitalization. This is in women, this is in men, and this was significant, both adjusted and non-adjusted to other factors. Regarding mortality, it's only the unadjusted difference. When adjusted, there was no difference between men and women, but there was a tendency to worse outcome in women, which we were not able to show in our group. We did some observations about renal dysfunction. We looked at a group of patients who entered our ICD or CRTD registry, and we divided them by renal function. We divided them to normal function, moderately reduced function, or severely reduced function. And as you can see, it's not surprising that the death rate, we are looking here at survival or freedom from death, and as you can see, the patients who had severe renal dysfunction had a higher mortality rate. This is not a surprise. But when we looked at this is the ICD group. When we looked at the CRTD group, this difference was nullified. In fact, there was no difference in the survival of patients at different levels of renal dysfunction. So the CRTD in some way corrected the excessive mortality of the patients with severe renal dysfunction. By the way, the issue of ICDs in chronic renal disease it's a very big question in the literature with different results coming from different sources, and I'll show you also the approach of the guideline committee. This is another work that we did out of this registry. In this work, we divided the patients to normal function, moderately reduced, mild to moderate, and severely reduced, and dialysis patients. And we were able to show that the prognosis as far as survival, as well as appropriate shock and inappropriate shock, was more or less the same between patients with dialysis and patients with severe renal dysfunction, but no dialysis. If we look at previous works coming from here and from other places in the world, this is again coming from the MEDI2 trial, where Goldenberg et al. Showed that in patients with GFR less than 35, there was no advantage to the use of ICDs at all. This is taken from a meta-analysis of the two MEDI trials and also the SCADEF trial that shows that as you go down the GFR, the advantage of ICD is decreasing. It is still there borderline, but it's going down with the decrease in GFR. The recent guidelines committee of prevention of sudden death and ventricular arrhythmia made a special review of this topic. Actually, they had a special review of several topics as base for the guidelines. And the writing committee concluded there was not enough data to inform a recommendation on ICD implantation in patients with end-stage renal disease on dialysis. Other patients, they did make a recommendation to implant ICDs, of course tailored to the individual risk factors and concomitant diseases. What could be the reason that primary prevention by ICD may not benefit severe chronic kidney disease patients? must have to do with competing risks such as non-cardiac death, cardiac non-arrhythmic death, EMD and asystole that are known to be more common in patients with severe chronic renal disease, and also may be a part of device complications. There also may be a question of risk stratification, whether the usual risk stratification done on basis of ejection fraction or NIHA really applies to chronic renal disease patients. This is just a quick look at the issue of age. In our patients, in our registry, these are the survival curves of patients who are below 65, between 66 and 75, and above 75. This graph shows patients with ICDs, and of course, it's not a surprise that patients who are older have a high mortality rate. But what was interesting that CRTD recipients in all groups had similar mortality. So again, CRTD kind of corrected the excessive mortality that existed in the ICD recipients, and the CRTD patients did almost as well even when they are older. And as opposed to the usual notion that patients have higher complication rate, although patients have higher complication rates, we had similar complication rates in all age groups. If we look at the literature about ICD in the elderly, there are conflicting results of several meta-analyses that looked at this. Some of them came up with the conclusion that every age benefits from ICD, and some of them did not. The guideline committee of the 2017 appointed a group to do a systematic review of the literature, and this is what they came up with of several series. All of them more or less pointed in the same direction, that ICD is beneficial, unrelated to age. And they came up with the following recommendations: that for older patients and those without significant comorbidities who meet indications for primary prevention, an ICD is reasonable if meaningful survival of greater than 1 year is expected. Just one word on the issue of patients with advanced heart failure, and we are talking about NIHA 3 because we did not implant NIHA 4 patients. This is a survival curve of patients with NIHA 1 or 2, and this is NIHA 3. Again, it's not a surprise that patients with NIHA 3 die more in the ICD group. And again, when we took the CRTD group, these are the curves of CRTD, this difference was corrected to a large part. We took a quick look at the issue of VF testing. As you know, VF testing, or what we used to call DFT, was very prominent quite a few years ago. How much time do I have? For a few more minutes. The practice of VF testing was very common until several years ago. Then it was questioned because many people felt that it was not related to clinical outcome, and there was also some risk in the testing. And as you know, over the last few years, about 3 or 4 years ago, there were 2 studies that were published, the Simple and the Nordic trial, that actually put an end to this practice of VF testing. We looked at the experience of the ICD registry starting in 2010, ending in 2015. There was a huge drop in the use of VF testing over the years, which is not surprising. It actually preceded the publication of the big studies on VF testing, and I believe that the situation is more or less the same here. The overall rate of VF testing is below 3% now. We looked at whether this issue of VF testing, although not randomized, of course, affected outcome, and we were not surprised that it did not affect outcome, whether survival or free of death or free of arrhythmia. The 2 groups, those who were tested and those who were not tested, did exactly the same. So is VF testing still indicated after Simple and Nordic ICD trial? I just want to call your attention that there were several groups that were excluded from these trials. One of them was the right-sided ICDs that we know from previous work have sometimes high DFTs. We know that ICD replacements tend to have, at least in the Canadian registry, had very relatively high rates of findings if you do VF testing. We are currently running a trial called the Simpler trial, Simple for Replacement trial, looking at VF testing during replacements. So far, we are continuing to do it because at least it has been reported that during replacement there are much more prevalent findings if you do VF induction. And there are other groups such as hypertrophs, dose modification, Rugada, subcutaneous ICD. Of course, the majority of patients do not need VF testing anymore. Larry, how much time do I have? Just to touch on two more points before I summarize. One of them is we looked at the issue of single versus dual chamber ICD. For those here who have some gray hair, we know that this has been a long, very long, persisting argument between the two approaches. Dual chamber have the potential advantage of the need for future atrial pacing if patient goes into sick sinus. Supposedly better discrimination between arrhythmias, maybe less inappropriate therapies. There were different publications on this. Better documentation of arrhythmias and better detection of silent atrial fibrillation. Whereas the potential advantages of single chamber ICDs are simpler, they're cheaper, better longevity. In most studies, there was no advantage of DDD in the prevention of inappropriate therapy. I had the privilege to be part of two studies. Actually, I was a PI together with a group of Mayo on two studies that looked at dual versus single chamber ICD in the previous decade. One of them clearly showed the DETECT SVT trial that was published in Circulation, clearly showed an advantage in discrimination between dual chamber. Dual chamber had a clear advantage over single chamber detection. The other one only showed that at least the understanding of the episodes or the diagnosis, post hoc diagnosis was better with dual chamber over single chamber ICD. So we looked at this issue in our group. The amount of dual chamber ICD, the rate of the implantation of dual chamber ICDs did not change too much over the years, but we had more single chamber ICDs recently because we decreased the amount of CRTDs. We looked at the results of VVI versus DDD ICDs over time, and in all aspects, including appropriate therapy, inappropriate therapy, heart failure, death, heart failure or death, in all of them they did exactly the same. So we were not able to show any significant difference between the group. And if we look at a similar work that was done out of the NCDR database on almost 30,000 patients, they did a propensity matched cohort. Although there were somewhat lower complication rate with the VVI ICD, there was similar one-year mortality, hospitalization, heart failure, so there was no significant difference between the two groups. I need to mention that this device was not included in the previous analysis. This is the DX model of ICD that is now available only from Biotronic, that may combine the advantages of both sides, except for pacing in the atrium. This is a single lead device with the simplicity of single lead, but it has a bipole that collects ECG or EGM in the atrium and gives us the information, but cannot pace. This may change the scheme of choice between VVI and DDD over time. The last point that I would like to mention is the change in use of dual coil versus single coil over time. This is our experience where dual coil leads decrease significantly, the use of dual coil leads decrease significantly over time, with an parallel increase in single coil ICDs. And we looked at the long-term results of both, and we were not able to show any difference. There seems to be a difference here toward the end of the follow-up, but the numbers here were small, and overall there was no significant difference between the two types of leads when used over time. This corresponds to this work that was published out of the NCDR registry that showed the same trend of decrease in the use of dual coil, increase of the use of single coil that was in this registry associated mainly with implanters who were electrophysiologists as opposed to surgeons, and those who are doing extractions, because if you do extractions, you know the difficulties of dual chamber, dual coil ICDs, and those tend to use more and more the single coil. So just a word on the use of subcutaneous ICD, because this is a new player in the field. There's great variability in the use of subcutaneous ICD so far because it's an emerging technology. I would just mention the American guidelines that you probably follow here, that in patients who meet criteria for ICD, who do not have vascular access or have high risk for infection, and who do not need bradycardia pacing, there's a one indication for implantation of subcutaneous ICD, and there's a 2A indication for patients who just do not need pacing for the use of subcutaneous ICD instead of a regular ICD. The European guidelines are a little more complex, and I'm going to skip them. The situation in other countries, not here, including my country, that there are strict indications for the use of subcutaneous ICD. We use them for bilateral venous occlusion, high risk for infection, previous infections of CIEDs, and the history of endocarditis. It is not readily available for use, as I believe it is here, but this is, I believe, a changing situation. It also has to do with price. So let me conclude, ladies and gentlemen, that using the registry information, we were able to show that there is very low rate of delivered